A very good evening to all our viewers and welcome back after a long hiatus. This is the fourth episode of the Surge Talk series for primary care physicians, an initiative by Sabah Surgical Society in collaboration with Gleneagles Hospital, Kota Kinabalu. Today, we have with us an esteemed speaker, Mr. Krishnan Sriram, who is a consultant colorectal surgeon and a general surgeon in Hospital Queen Elizabeth, Kota Kinabalu. Mr. Krishnan Sriram is the head of the colorectal surgery unit of Queen Elizabeth Hospital. He also heads the Enhanced Recovery After Surgery Committee as well as the clinical nutritional support teams in our hospital. He was granted the Sir Harry Anamuntodo Gold Medal Award by the National University of Malaysia in the year 2013 for the best performing student during the Doctorate of General Surgery course. Subsequently, he pursued his fellowship in advanced laparoscopic and robotic colorectal surgery in Taiwan and Korea. He is known for presenting topics pertinent to colorectal surgery in both the national and international arena. He has numerous publications under his name and is a keen researcher who is involved in multiple multi-center trials both in the national and international trades. Without further ado, let us welcome Mr. Krishnan Sriram, who will be presenting a topic which is, I would say, rather intriguing, entitled Pain in the Ass. Over to you, Mr. Krishnan.
Okay, thank you, Mr. Sendil. That was a very nice introduction. I'm Krishnan Sriram, the colorectal surgeon from Queen Elizabeth Hospital. In fact, Mr. Sendil, who just introduced me earlier, will be starting his fellowship in colorectal surgery as well. And soon he'll be back in Sabah to serve all this population and people in Sabah soon. Okay, without further ado, today's topic that we're going to talk about is actually pain in the ass. Basically means anal pain. Yeah, and when you look at anal pain, it's actually relatively commonly seen, especially in primary care. It usually comes with multiple different episodes, but most of the common presentation will be what you call this as a pain around the anus. Okay, sometimes they do present as emergency, where some emergency interventions need to be done. So most of us think that just anal pain is easy, but it sometimes can be very difficult and very challenging, even at a subspecialty unit like us. Yeah, and the outcomes, of course, varies a lot depending on the cause and why the pain is there. As we all know, anal canal or the organs around the anal cavity is actually very complex. So the pain around the anus could be because of any of these structures around the anal canal. Yeah, if you look at these anal or perineal disorders, usually make up to almost about 20% of surgical outpatient references. It can be very distressing for the patients and embarrassing most of the time. So they usually present very late when the pain is actually unbearable. Yeah, nobody wants to come to the clinic and then tell you that I've got a pain here. So most of them people are very shy. They tend to present when they really cannot bear the pain at times. Okay, just a short on the anatomy of anal canal. You know the anal canal, as you can see here, is roughly about 4 centimeters, but it can vary about 3 to 5 depending on the individual as well. Yeah, and when we see anal canal, the mid anal canal is usually in between the junction endoderm and ectoderm, where the dentate lines are. So you can actually see the multiple muscles are attached to the anal canal as well. And this is another interesting picture, which shows that rectum up there, then anal down here. Then this is what you have, the anal cushions around here, your internal sphincters and your external sphincters around this area. Yeah, okay. And this is extreme blood supply of the anus is very rich blood supply. It supplies both by the inferior mesenteric artery as well as the branches of the internal pudendal artery. Yeah, so it's a very vascularized organ around that area with extensive drainage, and even the nerve supplies around this area can be very complex as well. So most of the time, the nerve supply above the dentate line, usually more of patient don't have the pain most of the time, yeah. Whereas the pain, the nerves that supplies more on the lower part are usually the pain sensitive zones. So, any procedures or any around this area usually will cause very significant pain for these patients, yeah. And as I said, sphincters, yeah, you have internal sphincters, external sphincters. Internal sphincters are what actually basically you don't control them, where external sphincters are what we actually control them to a certain extent, yeah. When you look at the internal sphincters down here, it actually continues as the wall of the rectum when it goes up, whereas the external sphincters continues as the pelvic floor muscles, either could be iliococcygeus, puborectalis, levator, basically levator ani muscles, yeah. Okay, so why do patients present with anal pain? Yeah, it could be a lot of causes, as I said earlier. It could be because of anal fissures, perianal abscess, fistulas, sepsis around the perineal region. Could be because of fistula in anus, trauma for that matter, yeah. We'll talk about it later. Hemorrhoids, yeah, cancer, yeah, something that we really have to think about and always keep in mind at the end. Lastly, I'm going to touch a bit on this very funky name called proctalgia fugax. We're going to talk about it later. Yeah. Go about hemorrhoids. Most of the time, generally, hemorrhoids do not cause pain. Yeah. So when patient presents to you and you think the pain is because of hemorrhoids, it has to be most of the time thrombosed. Yeah. Unless thrombosed, hemorrhoids do not usually cause pain. It could be either both internal hemorrhoids or external hemorrhoids as well. And most of the time, the normal hemorrhoids without thrombose, they usually present as either prolapse, itchy, swollen, or sometimes rectal bleeding. Yeah. Okay. So when you say hemorrhoids, talk about it. These are the part of normal anodome cushions. Yeah. Everybody has got anal cushions around this area. These are actually not veins but sinusoids. Yeah, this you can actually see where the veins are communicating. They form like capillaries, normal sinusoids. Hemorrhoidal cushions provide about 15 to 20% of resting anal pressure and feed vital sensory information. Basically means that anal cushions around here, hemorrhoidal cushions, also plays a role in terms of continence and for us most of the time and control the motion. Yeah, there are three main cushions, which is at about 3 o'clock, 7 o'clock, and 11 o'clock. Yeah, you have internal hemorrhoids over here. It could be external hemorrhoids, or sometimes it could be a mix of both internal and external hemorrhoids. Yeah, why do patients get hemorrhoids? It could be either constipation or straining, even diarrhea. It's not always because of constipation alone, diarrhea, and of course you're talking about fiber diet, the type of diet they're taking, the aging, pregnancy, obesity. These are all increases the chances of someone to have hemorrhoids. Yeah, again, this is a picture that shows internal hemorrhoids and external hemorrhoid, which is actually thrombosed. Yeah, you can actually see it's a bluish area down here, whereas the internal hemorrhoid usually is much more higher up. Yeah, hemorrhoids generally we put them into grades, whether they bleed but without prolapse, whether they just reduces but we can easily push them back, or you need someone manually to be reduced, or they not reducible. Yeah, and management, when you talk about thrombosed external hemorrhoids, basically just incise, evacuate the clots. Yeah, the minute you evacuate the clots, patient feels extreme comfort. Yeah, whereas thrombosed internal hemorrhoids, most of the time we go on conservative, supportive, but if it doesn't really subside with that, then most of the time you need some surgical intervention. And generally when you talk about hemorrhoids, treatment besides what we talked about earlier is actually talk about dietary modifications, stool softness, probably get some Deflons, and of course sitz bath to actually soothe them and reduces the edema, itching and pain to a certain extent as well. And when you talk about surgical intervention, it can either be rubber band ligation, laser hemorrhoidoplasty, stapler, or ligation, or open hemorrhoidectomy. This is actually a simple picture which actually shows rubber band ligation. It could be either suction type or the old method with clip and you put a band on it. Yeah, this is a picture of how laser hemorrhoidoplasty angioplasty is done. Can you see the light over there? That's actually the laser fibers gone in there to burn off the sinusoids over around this area, humeral plexus. And this is a picture of stapler hemorrhapexy. And so the next cause we're going to talk about is actually anal fissure. Anal fissure generally is actually quite common, and most of the time it subsides by itself and just heals, and patient usually presents with painful defecation. They feel like something is cutting through, usually like passing through glasses to the anus, may be associated with rectal bleeding, especially when they tell you there are streaks of blood they see on the stools. Pain can last almost 1 to 2 hours even after each defecation. So it's just not at the time of defecation alone, but even could be after the defecation. And one of the most common causes is actually constipation, and most common sites are actually 6 and 12 o'clock. But if you see fissures are coming at other sites like 3, 9, then we might, most of the time we need to consider whether these fissures are of other causes. And this is actually a picture which actually shows a fissure over here, and when then you see a hypertrophied anal papilla, then most of the time this is actually a chronic fissure. We'll talk about it later as well. This is another picture of shows how the fissure goes down. So most of the time, as I said, the below the dental line where all the sensory nerves are here. So most of the time this can be extremely painful for patients. On top of that, when there's so much of pain there's always some spasm that happens around that area, which again causes worsening the pain and for them to pass motion. As I mentioned earlier, pain actually causes spasm, and then spasm leads to poor blood supply around that area, and again leads to poor wound healing, and then it persists and become a chronic fissure. As I said, can be acute, which is less than 6 to 8 weeks, or chronic fissure after that. And acute fissures, I said, usually have very severe pain. When you examine them, it's actually a clean linear tear. Most internal sphincters almost the same size. Whereas with chronic fissures, mild to moderate pain, you can actually see some granulation tissue around the area, and you can see the internal sphincters are a bit slightly hypertrophied, especially when you do endoanal ultrasound, and sometimes you do see skin tags around that area as well. This is just an example. Just an acute fissure is a simple pure fissure, whereas a chronic fissure you do get sentinel pile, skin tags, and the whole area here is hypertrophied. And treatment in acute phase, basically most of the time is just medical management. It's either diltiazem cream or GTN cream, analgesia, high fiber diet, lignocaine gel, stool softness. And whereas in chronic phase, most of the time we tend to continue medical treatment, but if it fails and is really unbearable for patients, then we do consider sometimes Botox or surgical intervention, which is we talk about lateral sphincterotomy. One of the biggest risks thing that we need to look at when we do a fissure is actually risk of incontinence. Cutting muscle more than 1/3 of the sphincters sometimes can lead patients into incontinence. This is an example of how lateral sphincterotomy is actually done. It could be either open method, or it could be a stab method. You put in a knife inside and then you cut the sphincters lateral to that. Mostly done at about 3 or 9 o'clock. Okay, and the amount of muscle that you cut usually has to be at the level or slightly above to the extent of the tear. So if you cut just a little bit, whether the tear goes much more higher up, usually would not give you a very good results as well. Okay. Next, perianal abscess. Perianal abscess is, I think, most very common. Everybody knows perianal abscess. Most of the time they present as actually emergency. It's cryptoglandular in origin. Most originates from the anal glands infected, and then it spreads around that as well. Can be perianal abscess, intersphincteric, ischioanal, ischiorectal. So it's depending on the site of the abscesses. This is an image how abscess actually can present as simple as this, or could be extensive or swelling around this area. This is an example where abscess forms around the ischial rectal area. Yeah, this is just a simple perineal abscess. When abscess forms in between the internal and external sphincters, it's called intersphincteric abscess. When the abscess forms much more higher up above the pelvic floor muscle, supralevator abscesses. Yeah, and standard of drainage or abscess is actually drainage. Yeah, and of course antibiotics. You need to do a proper drainage, proper irrigation. Incomplete drainage probably most of the time leads to recurrence of abscesses. Yeah, sometimes this could be due to a fistula as well, but 25% of perineal abscesses will end up as a fistula at the end of the day. So you're not sure whether the fistula leads to perineal abscess leads to fistula, but it's definitely interrelated to each other. Yeah, this is an example of how a simple perineal abscess can be drained just by making a cruciate incision or just linear incision. Let the pus out and curate the tissues around that area and let it granulate from inside to outside after that. Yeah, and fistula in ano. Yeah, subsequently the next topic that we're going to talk about is actually an abnormal connection between the two epithelialized surfaces, which is right most of the time from anus all the way to the skin outside. Yeah. Most of the time patients present with intermittent pain, discharge together with the pain. It's always a cycle where patient feels that they have a tremendous significant pain, and then the pus ruptures, discharge comes out of the fistula, they feel better, and after a while the cycle starts again where patients start having pain and it ruptures, patient feels better. So it's continuous thing if we don't treat them. And there are different types of fistulas: intersphincteric, transsphincteric, suprasphincteric, supralevator, and all these need to be done imaging. A standard rule when you talk about fistulas, basically any fistulas that you see anteriorly, yeah, most of the time are straight, but any of the fistulas that you see posteriorly, most of the time they curve down and opens at the 6 o'clock. But this is not 100% rule. Yeah, this also has exemptions, such as if the fistula is more than 3 to 4 centimeters away, or if the fistula is secondary to other causes such as TB, Crohn's, malignancy, then they don't fulfill this rule most of the time. Yeah, and this is the classification of fistula. I think everybody is aware of this. Intersphincteric fistula is the most common fistula we see, which comprises almost about 70%, and subsequently about transsphincteric fistula, which takes up about 25% of fistulas, and suprasphincteric 40%, and extrasphincteric 1%. Yeah, and the prognosis of the results of the surgery also depends on the type of fistula. Intersphincteric and transsphincteric fistulas usually will have a better results when you compare with suprasphincteric or extrasphincteric fistulas. Yeah, when you treat fistulas, the dilemma is always when you talk about recurrences and incontinence. You want to prevent recurrence 100%, the patient will definitely end up with higher incontinence rate. But when you want to preserve incontinence, the recurrence might be much more higher. So it should be a balance between these two when you treat a complex, especially complex fistulas. Yeah, it's very important for imaging. At least we do endoanal ultrasounds before each intervention, and nowadays when it complex or recurrent fistulas, we usually get an MRI before we actually operate on these patients. Yeah, this is an example of an MRI which actually can see the tract, and whereas this is an endoanal ultrasound where you actually can see the tract following along the tract around their side. Yeah, and of course for the treatment depends on the if there's an infection associated with the abscess. I mean fistula at the time, drain the abscess, control the infections. Antibiotics alone usually would not heal the fistula. Some people believe that giving antibiotics long will heal, but it will never heal the fistula. Yeah, they need definitive procedures. Either could be a fistulotomy, fistulectomy, ligation of intersphincteric fistula tracts, laser surgeries, video assisted, or fibrin glue. However, most of these procedures, the advanced procedures, especially the minimally invasive procedures, the recurrence rate can be quite high, as high as almost about 30% sometimes. Yeah, And this is an example. Picture actually shows that laser fistula, where laser has been introduced into the tract and you burn off the tract along, you come down. And this is a ligation of intersphincteric fistula. You make an incision between the internal and external sphincters, go in between, ligate off the tract, separate this tract, and core out or excise the other tract. Yeah, this is a video assisted surgery. Yeah, the next cause of perineal pain is trauma, and most it could be either because of road traffic accidents, but most of the time when road traffic accidents, it can be a very serious problem and usually associated with other injuries, other such as pelvic fractures, and so on. And sometimes trauma could also be because of childbirth, especially sphincter injury during the vaginal deliveries. It depends on how much of sphincters involved at the time as well. Okay, but you do have some people who actually self-induce trauma, especially when they do some sexual games, inserting all kind of materials down the anus. This indirectly could also cause a bit of trauma, and patient might present to you with pain around the anus as well. Yeah, and another thing that you do see sometimes, but not very common, is actually prolapse or intussusception. Okay, when you see the rectum is seen outside the anus, most of the time we say it's actually prolapse. But sometimes the rectum just telescopes down into the anus, but it doesn't protrude down into the anus and outside. So in this, it's actually called intussusception. But when you look at it, it's actually almost the same. Yeah, prolapse is very easy to diagnose because you can actually see it coming out. Whereas when it called for intussusception, you need to have very high degree of suspicion. Yeah. And rectal prolapse, basically abnormal movement of rectal mucosa down or through the anal opening. It can be sometimes be just a mucosal prolapse, or could be full thickness prolapse. And most of the time, this is actually associated with age, diarrhea, constipation. Yeah, but we don't see so much in our part of the country. Yeah, or part of the Asia here. It's actually cystic fibrosis or celiac disease. Any trauma to the pelvic floor, even childbirth, increases the risk to someone to develop prolapse later in their life. Yeah, and this actually shows the partial thickness. You can actually see the wall is actually still there, only the mucosa is protrudes out. So this is called partial thickness, whereas the entire wall of the rectum completely protrudes out. This is actually a full thickness rectal prolapse. And this is actually shows intussusception, where you can actually see the wall of the rectum intussuscepts down, but it doesn't protrudes out of the anus. So this is called intussusception. The example of full thickness rectal prolapse, mucosal prolapse. Yeah, you don't see a full circular lines when it comes to just a mucosal prolapse alone. Yeah, and treatment, most of the time when patient comes to you with a pain and prolapse, reduce the thing immediately before the edema sets in. Yeah, the longer the wait you wait, the more the edema, the more difficult, and the more the pain as well. Okay, indirectly we need to treat the underlying condition. Why do patients develop this at the same time? Yeah, but if it's recurrent, then you need surgical intervention. Could be either abdominal approach or perineal approach. Yeah, this is some of the pictures that actually shows abdominal approach, where you dissect, you pull the rectum up, you ligate it, or sometimes some people do put a mesh at times. Yeah, this is the perineal approach, where you excise the entire mucosa that comes out, and you re-anastomose back. Yeah, anal pain and malignancy is very much interrelated. Yeah, most of the time any patient comes to us with this, back in our mind we always think, could it be malignancy, especially when someone is of elderly age or more than 40 years old. Yeah, it could be either just anal cancer, which can be seen outside, or it could be a low rectal cancer. You only can see this when you do a digital rectal examination. Yeah, rectal cancers are mostly adenocarcinomas, but when you call by anal cancers, it could be either adenocarcinomas or squamous cell carcinomas. Yeah, why we must know about colorectal cancers? Yeah, colorectal cancers is actually the second most cancers in Malaysia, second for females and first for males. The incidence is quite high, almost about 21.3%, and is highest in Chinese population, followed by Malays and Indians. And if you look at the graph here, look at cancer registry, colorectal is the highest for males, whereas second for females. Yeah, okay. And any patients that you suspect with any of these urgent attentions coming with anal pain, always think whether is it something about malignancy, especially rectal bleeding, healthy bowel habits, significant weight loss, unexplained anemia, or any palpable mass, rectal or abdominal. Yeah, always think whether this is actually malignancy. This is an example of malignancy. Just shows how the scope is done to biopsy those lesions here. Yeah. Okay, proctalgia fugax is something that's diagnosed on exclusion after you exclude all the other cause. There's no specific cause why the pain comes in. Most of the time, it's hypothesized that the pain is actually the spasm of the pelvic floor muscles around the anus. Yeah. The episodes can be very severe at times, and most of the time sometimes do limit the activities of some person on the day. Yeah, the pain comes and stops by itself, and it can come back any time after that as well. There's no aggravating or relieving factors at times. Yeah, and usually diagnosing is made after excluding all the other causes of anal pain. Yeah, you look at the image here. There are so many muscles around the anus. Yeah. And spasm of these muscles is what basically talk about the proctalgia fugax. There are other few syndromes, elevator ani syndromes, and so on. But I think what we understand basically proctalgia fugax is something that we usually see quite a bit more. And most of the time, the management is just very much of supportive in terms of sitz bath, relaxation techniques. Yeah, if the spasm is worse, Botox sometimes could relieve the spasm. GTN or diltiazem cream. Subsequently, it's actually biofeedback or stimulation. Stimulation is basically you divert the pain. Yeah, you put a probe in, you do some electrical stimulation, and the brain senses that electrical stimulation rather than pain in certain cases. Yeah. Okay. Ladies and gentlemen, painful anus can be very difficult to manage at times. Always should have high index of suspicion whether it's actually malignant or not malignant. It should be sometimes could be the early signs of malignancy when they present to you. Though most of the time it's benign, but you should have a strong impact on the. But most of the time the pain can have a very strong impact on the quality of their lives. Sometimes they end up not going to work, might not going to school, and so on as well. Hence, actually, at the time, a referral to a colorectal surgeon is extremely important, especially the problem persists and doesn't improve. With that, follow us at these websites talking about colorectal surgery Sabah, and thank you very much.
Thank you, Mr. Krishnan, for that very enlightening talk on the various pathologies causing pain in the anal canal. Interesting, isn't it? Such a small space, and there's so many problems in it. Well, that's how life is. And to move on, maybe we will invite our viewers with any questions to insert your questions in the comment section of our YouTube channel, and we will then ask these questions to our speaker. So we have with us a question from the floor. Okay, are fistulas always treated with surgery? Laser surgery, as you mentioned, is shown to have better outcomes than open method. What is your take on this, Mr. Krishnan?
Okay, I don't believe that laser surgery has got better outcomes than open surgeries. It all depends on the type of fistulas, okay, and the techniques of the laser has been done. If you look at the literatures, laser surgeries has got higher rate of recurrence of almost about 20 to 30% compared to open surgeries such as fistulotomies or ligation of intersphincteric fistula tracts. Yeah, but one thing good about laser surgeries is very minimally invasive, so you don't have extensive scars around the anus or big wounds around the anus as well. So most of the time we tend to do that as a first line sometimes to offer them something which is minimally invasive, But if the thing recurs, then you definitely need up something more aggressive or more advanced surgery for them as well.
All right. So basically it depends on the type of the fistula, and open surgery is better than lasers when it comes to treating most fistulae. The next question is related to hemorrhoids. I believe this is from a primary care physician. What immediate treatment can be offered at the primary care setting or clinic setting for patients who present with thrombosed or strangulated hemorrhoids? Is reducing the hemorrhoid recommended? And what care should be taken when attempting reduction in the clinic setting?
Okay, I think that's a very interesting question. When we talk about hemorrhoid, thrombosed or strangulated hemorrhoid, as I said, it's important for us to know is external or internal hemorrhoids. Okay, external hemorrhoids cannot be reduced. You can attempt a small incision, and in fact, if you actually can see it, if you're confident. But if you don't think, then it should not. But for internal hemorrhoids, there's nothing much can be done. If you can afford to reduce the hemorrhoid, that'll be good. With adequate of analgesia or a bit of sedation, usually before you reduce the hemorrhoids. Some patients might scream in pain, especially when it's thrombosed and you try to reduce them. Yeah. In these kind of situations, adequate painkillers is one of the things that we always start. And you could actually start a bit of Deflons, high dose of Deflons. We go up to almost 1 gram 3 times a day. Yeah, it's not to prevent or reduce the hemorrhage size, but basically strengthens the walls of the vessels to prevent further bleeding or bleedings at that time as well. So the simple maneuvers I think can be done at the primary care setting. Basically, I would say analgesia, and supportive care in terms of sitz bath and Deflons at the moment. But if you think you can reduce it and patient is cooperative, it's good to be reduced it as well.
Okay. Hemorrhoids is a common condition that presents to the clinic setting in pregnant patients, and most of the time following delivery, this hemorrhoids usually resolve by themselves. However, the patient needs to put up with these hemorrhoids and the issues surrounding it for close to 40 weeks. So what are your advices for these patients who are pregnant and present to us with hemorrhoids?
Okay. Pregnant ladies' presentation with hemorrhoids, it's very common. Why it happens, it could be few reasons. One of it, of course, is the gravid uterus. Second is actually because most of the time pregnant women will have to a certain extent a bit of constipation, and both of it together with a bit of straining will lead to hemorrhoids. The most important thing is actually the lifestyle modification for these patients. Most of the time we don't intervene with any surgical intervention unless it's something that's emergency. Conservative as much as possible. So to prevent this, of course, first of all is actually to prevent constipation. Prevent constipation is the key in preventing, basically, to a certain extent, in hemorrhoids, especially in pregnancy ladies. So prevent constipation. You can't do anything about the gravid uterus. And avoid straining. That's very important as well.
Thank you, Mr. Krishnan. And for patients presenting with perianal pain or fissures, some even present with hemorrhoids and the various pathologies, common pathologies which you discussed earlier, would you reckon a colonoscopy is mandatory or should be recommended for these patients? And if so, when and who should we refer to the tertiary care setting for a colonoscopy?
Okay, anybody more than 40 years old presents or any of the anal problems, I will always have something against or back in my mind whether this could be a malignancy, especially hemorrhoids. Hemorrhoids sometimes could be a presentation that presents to you, but on examinations that you actually see there's actually rectal tumors or even colon tumors higher up. So if whether to do a colonoscopy or not,
I would say depends on the whether this is the first time or is it a multiple times coming with the same problem. As I said, if the problem recurs again and again, is not healing, then you always need to look at whether it's secondary causes. Might not be just malignancy, it could also be because of TB or inflammatory bowel disease and so on. Besides that, if it's not, I would say anybody more than 50 years old, I would offer a colonoscopy, especially as part of the screening as well. So, yeah.
All right. Thank you, Mr. Krishnan. And so far, yes, we have a question here. How does sugar dressing help with edematous external hemorrhoids? Can ceton insertion be practiced at the clinic setting? Both questions come from the same viewer.
Okay, sugar dressing basically reduces the edema. That's how basically it improves the swelling or edema around that area. Yeah, it doesn't really lyse the thrombosed hemorrhoids or clot, but it basically reduces the edema. When the edema subsides, the pain improves to an extent. So that's the whole idea of sugar dressing at times. Yeah, but again, for external hemorrhoids, if you think it's a thrombose, as I say, sugar dressing might not work at times. It works very much for prolapse hemorrhoids or prolapse hemorrhoid without any thrombosis or strangulation. Yeah, but if there's already a thrombosis component in it, then the pain is actually because of the clots which has been accumulated in a very tight small space per se. Second question, talking about cetons in primary care, I wouldn't recommend that because it's even we don't do that in the clinic settings. We always bring our patients to operation theatre to examine under anesthesia. You need to look at the cavity around properly and see exactly where the fistula is, whether there's opening somewhere else or not as well. And probing into a fistula blindly can actually cause more trouble. You might end up with more false tracks, which is more difficult to manage later after that as well. So if you ask me, I will definitely not advise for cetons in the clinic setting.
All right. There's been a lot of questions coming in. I'm sure this is a very interesting topic, probably because it's a common problem that we face in the primary care setting. The next question is about topical analgesics and suppositories for hemorrhoids. Can NSAIDs like boron gel or diclofenac plus gel be used as an analgesic topically for hemorrhoids?
Hemorrhoids per se, we don't really, I've never practiced giving a Voltron gel or diclofenac gel over the hemorrhoids, but there are some gels that you see in market which has got a bit of lignocaine and there's low grades of steroids on it, which actually reduces the edema and pain around that area as well. That's one of the topical gels we can actually practice, but I've never practiced about putting a diclofenac gel around the anus. There are some suppositories such as Anisol, or some people call it Anucare, reduces the edema to a certain extent. The swelling also can be practiced in terms of the pain for the hemorrhoids as well.
Okay, it's quite a number of questions on hemorrhoids. The next question will be on fissures, and particularly speaking about chronic fissures. So in management of chronic fissures, what is the rate of recurrence for non-surgical management, and following surgical management or lateral sphincterotomy, as you mentioned in your talk earlier, what is the recurrence rate?
Okay, the recurrence rate can be very variable. Most of the time, once it's a chronic fissure, it will not heal, so there's no such thing as recurrence. But most of the time, the patient's symptoms gets better over time. Yeah, so symptoms get better. When the symptoms get better, most of the time we don't intervene on this kind of patients. Yeah, acute fissures, of course, heals most of the time. Almost about 75% or more fissures heals within the first 6 weeks. Yeah, so the one you see as a chronic fissures is the last 25% or so on. Yeah, When you do lateral sphincterotomy, again you are not taking out the fissure. What all that we are doing actually to relieve the spasm around the anus, so that the healing will improve. As I say, one of the risk factors for the fissures are actually the blood supply because of the spasm. So healing improve and patients have lesser pain at the time of defecation.
Thank you, Mr. Krishnan, for that enlightening answers and the wonderful talk, and taking us for a walk around the anus, looking at all the pathologies possible in that small tight space. Well, I think it has been a productive evening, and with that we come to an end of the 4th episode of the Surge Talk series, organized by Sabah Surgical Society in collaboration with Gleneagles Hospital, Kota Kinabalu. So stay tuned with us and be updated about the next episode on our Facebook page, the Sabah Surgical Society Facebook page, and we hope to see all of you all in the next or the 5th episode of the Surge Talk series for primary care physicians. Thank you.
Thank you.